So may I just introduce to the audience Professor Tara Renton, who is a specialist in oral surgery and orofacial pain, and runs her practice out of King's College London, but also an MDT with Professor Hopkins at Guy's and St Thomas's. I cannot stress to you the importance as trainees of learning how to differentially diagnose facial pain, because a lot of patients get referred to our rhinology clinics and specialist rhinology clinics by colleagues and also by general practitioners with a history suggestive of sinusitis. And I think it's extremely important that you're able to discriminate between the different causes of facial pain. And I am delighted that Tara is going to enlighten not only the audience, but me as well. So I'm really looking forward to this presentation.
As Raj mentioned, I am very, very privileged. I run a multidisciplinary clinic at King's College Hospital, which Claire sometimes comes to. I also go to Guy's and St Thomas's, where we do specialist MDTs as well. So I work with headache neurologists, and you'll see the relevance of that in the lecture, ENT, neurosurgeons, pain management, clinical psychs, and a psychiatrist, and a whole dental team as well. And most of the work I present and talk about, there's two pro bono websites. One is trigeminalnerve.org.uk, and this one is orofacialpain.org.uk. And I'm creating a new page just for ENT specialists. So today, really basic, to give you an overview of differential diagnosis, illustrate a variety that can be mistaken for rhinosinusitis, and maybe give you some tips about avoiding the diagnostic traps. And you'll be aware of the definition of orofacial pain. And pain, chronic pain particularly, is very complex. It's a massive societal burden. Talking about 30% of households currently suffer from headaches or joint pain, back pain. And obviously orofacial pain is fairly complex because it's involving all the different areas. But chronic pain doesn't have to be a physical entity, so it doesn't have to be caused by physical damage, or most of the pain patients we see are post-traumatic neuropathic pain in my clinic. But obviously pain can be emotionally evoked. And pain is a bit, I say it's a bit like love. It's very complex. It's more emotional than actually a sensation. And that's why it's so important that we treat the patients holistically, listen to them, take their complaints seriously, but also work with psychologists. We do a huge access to psychology assessment in these patients, picking up huge mood disorder problems, anxiety, depression, personality disorders like Prof was talking about, not necessarily body dysmorphia, but we pick up a lot around personality disorders and delusional disorders and all sorts of stuff, which keeps you out of trouble, frankly, going forward with managing these patients. Now, for those of you who are not familiar, there's a new recent classification of pains. We used to say there's four healthy pains, four types of pains, two healthy and two non-healthy. We talk about pain being we think of pain as being a symptom, and pain is a symptom in the healthy pain. So this is nociceptive and inflammatory pain, post-surgical or infective type pain, or actually pin stick type pain. And these are healthy pains, they're protective pains, and these are pains as symptoms. Whereas the unhealthy pains, your neuropathic, by definition, a lesion of the nerve, either peripherally or centrally, or nociplastic, which is the idiopathic, fibromyalgic, chronic widespread pain. These are the unhealthy pains. These are a disease of the neuromatrix. And therefore, pain in these conditions is not a symptom, it's actually a disease. So that's something you really need to get your head around. And a lot of the pains we're talking about today are in this group. So when we talk about classifying different pains, we go to the International Classification of Headaches. The ICHD-3 was released, version was validated just a couple of years ago. And you can see here there's three categories. There's primary headaches, which are very relevant for you guys. Secondary headaches, less relevant, and orofacial neuralgia, as they call it, which is an unfortunate term. But actually, we've published just recently that now we have a separate intraoral classification of orofacial pain published in Cephalalgia in January last year. I was one of the co-authors, and this actually looks at including acute as well as chronic orofacial pains around the dentoalveolar intraoral facial region, which are also relevant to you guys. So you need to be aware of these new and relevant classifications of pain. So I've talked about the prevalence of pain. It's really very impactful. It's costing our economies an absolute fortune. And about 9% of patients actually have post-traumatic neuropathic pain or disease-related neuropathic pain, diabetes, some such. The interesting thing about trigeminal pain is not too difficult to understand, but the impact, the affective component, limbic component of trigeminal pain is massive. When you think about the trigeminal sensory nerve being the feedback, the sensory protector for eyes, ears, mouth, sinuses, meninges, breathe, all those important functions, breathing, eating, speaking, basically our life enjoyment is all around here. You can see why the limbic association, the impact associated with either expected or threatened trigeminal pain or ongoing trigeminal pain is massive. And we've been showing this in some of our MRI studies that we do around pre and post-surgical pain, neuropathic pain, and headaches, cluster headaches. The trigeminal nerve is obviously very complex as well. It has several complexes. So it has a substantive limbic component, which I've mentioned. It takes up over 50% of the somatosensory cortex because of its importance. And there's a significant amount of autonomic connectivity, psychogenic connectivity, and also there's a trigeminal-vascular complex as well, which drives our neurovascular pain. And as I mentioned already, the fact that it protects all these really important regions underpins why patients' lives are so miserable when they're having either episodic or continuous chronic pain. The other problem we have is the siloed training that we have. So we have one nerve and three professions. I would argue we have a lot more. So if you're a dentist, basically, and a patient comes in with pain around V2, V3 regions, so maxillary or mandibular division of the trigeminal nerve, we think it must be dental pain. And actually, to be honest, most often it is dental pain. Dental is the most common acute presenting orofacial pain. However, if you're an ENT surgeon, if you have a patient presenting with midfacial pain, you're going to immediately think about possible sinusitis. And hopefully at the end of this lecture, you will not be thinking that immediately. And then for others like neurologists, back surgeons, they will be thinking about, and general medical practitioners particularly, if they come across midfacial pain, they will think immediately often trigeminal neuralgia rather than toothache. We see many patients on long-term carbamazepine toothache. We have neurosurgeons booking patients with NVD when they in fact have toothache. So there's this real miscommunication predominantly around our siloed training. And patients, unfortunately, are the butt ends of this. And your heart sinks when the patient says, oh, well, I've seen 15 specialists and they've told me this, that, and the other, and I've had this many procedures done. And around 25% of our patients, a quarter of the patients we see, have been misdiagnosed along the pathway. And we're talking these two patients, one 3.5 years and one 4 years. They actually had adenoid cystic carcinomas, and they'd be treated for dental pain, for sinus pain, for trigeminal neuralgia, idiopathic facial pain, and headaches. So we're all culpable as specialists in our little siloed areas of not talking to each other. And you've got to remember that actually oropharyngeal carcinoma, there's 3 diseases in that combination. There's HPV-related oropharyngeal carcinoma, usually later on, mid-late life in men who've had a good time when they're younger. And then you've got the squamous cell carcinoma of your oral region. In those, one group in those with high risk, alcoholism, poor hygiene, smoking, all the local risk factors, pan chewing, for example. And then a small group, unfortunately, 19, 20-year-olds, no risk factors, very highly aggressive squamous cell carcinoma in the mouth, the oral mucosa. And that's increasing. One of 3 cancers, hepatocellular, melanotic, and oropharyngeal carcinomas, are the 3 cancers increasing in our Western societies. There are a few papers out there that have tried to sort of unwrangle the diagnostic difficulties around orofacial pain, and none of them really are ideal. Every author has their sort of bent and their sort of bias. And I wouldn't really recommend any of these 3. This is actually written by ENT surgeons. It's a fantastic effort in the Lancet, or the BMJ rather, but it misses out toothache, which is just crazy. But anyway, so we're actually in the process of developing a diagnostic app, but we've probably got another 18 months before we can actually release that. So when you look at the diagnostic commonality, which things happen commonly? Well, toothache is the most common acute orofacial pain condition, particularly in kids. It's very, very common. But if you look at the sort of lifetime prevalence in the general population, then we're talking about headaches. Remember, headaches can include hangovers. So headaches are the most prevalent in this sort of lifelong prevalence when we're assessing that. Toothache is second. Migraines, which come within the headaches, but they're about 11 to 15% of the population. And migraine is the big thing that you need to think about from here on in. It's a great mimicker. In our clinic, 30% of our patients presenting with idiopathic facial pain have migraines. So this is something you guys need to be familiar with by the end of this presentation. Jaw joint pain is the most common chronic pain that we'll see as dentists, and that's probably mainly migraine related. We're beginning to think, I've got a PhD working on that at the moment. But that's basically jaw joint pain, which you can familiar with pain, you can palpate the joints, and if they have localized pain in the jaw or localized muscle tenderness in the masseter temporalis, then they've got probably temporomandibular disorder, but most likely that's associated with migraine. Then you've got your sinusitis, but we know that sinusitis is rhinosinusitis, chronic, is very rarely painful. So what is that actual diagnosis? And I've got a few papers that have actually bottomed this out. So you can see at the bottom, trigeminal neuralgia is incredibly rare, as is some of the trigeminal autonomic kephalalgias, for example, cluster headache, but you do need to be aware of those. So let's kick off with headaches, because this is the most relevant area for you guys. So I'm going to go through headaches, how they mimic midfacial pain, how toothache mimics midfacial pain, and how temporomandibular disorders mimic midfacial pain. So exclude sinister headaches. If you've got an older patient over 50, like me, who presents with sudden onset and worsening headaches, possibly associated with neuropathic signs or dizziness or vertigo or other localizing signs, then obviously you've got to consider a possible sinister headache. Only about 1% of those presented with headaches. There's a lot of debate amongst the neurologists about whether tension headache actually exists at all, but there we go, it's there, it's in the ICH-D3, we accept that it's there, and it's the most common headache. Possibly postural, possibly dehydration related, possibly raised computer use, laptops and phones, including cervicogenic type headaches. Medication overuse headache is now increasingly common, so patients who have handbags that rattle, full of paracetamol, codeine, NSAIDs, all those over-the-counter OTC drugs. If you take those regularly, you will actually end up diminishing your endogenous pain mechanism and you will have more pain. So if you have a migraine type background, you will get headaches. If you have an IBS or you have a vulvodynia type background, you're more likely to get the back pain or the abdominal pain. So we know that those chronic use can actually reduce your endogenous pain mechanism. Migraine is the most significant, most impactful as far as patients are concerned. And then for those of you, hopefully you've heard of trigeminal autonomic kephalalgias. They are a group that actually are cluster type headaches, and I'll talk about some of the features as we work through the presentation. So this is why migraine can present as rhinosinusitis or as episodic toothache type pain, because basically your meninges V2 and V3 meninges are actually supplied by the trigeminal nerves V2, V3. So this explains why migraines can present in the face. And we've just written a series of 60 patients that we've seen in our clinic that actually present with episodic V2 bilateral or unilateral pain. And in fact, they have isolated V2 or some V3 migraine. So migraine doesn't have to be, as you can see here, this is a classic migraine, V1, V2, V3. We'll think about headaches just being up here, but actually migraine classically is the whole side of the face. But migraine can present isolated V3 and V2 or V3, V2. And then classically, the other diagram you can see here is this sort of rhinosinusitis type image. Between 85 and 90% of those patients presenting with self-reported sinus headache or painful rhinosinusitis do in fact have migraine. This is what you really need to pick up on. In our clinic, we pick up on 3 groups of these patients presenting with facial migraine, which the neurologists don't like us calling, obviously because facial nerve is a motor nerve. But we call it that just to make it simple. Basically, the patients either have a previous ongoing migraine history, and when you ask the patient, well, when you get this really intense throbbing episodic pain here, do you have the headache, migraine headache at the same time? They know they've got a migraine history. Oh yeah, no, it happens at the same time. So there's one group of patients that have the ongoing migraine that happens at the same time as their facial pain. Second group of patients have a past history of migraine that may have stopped when they went through menopause or through pregnancy. So their migraines have stopped, but it's come back. Instead of being here, it's now here or here or here or here. And the third group of patients basically have no history of migraine and de novo in their late 30s, early 40s, present with isolated V2, V3 migraine. So those are the groups you need to think about. Diagnosing migraine is really easy, and basically you can use your HIT6 questionnaire, which is really simple. And basically, if you get a score of 50 out of 120, then it's probable migraine. Migraine is about 70% genetic. There's a lot of it's familial, so most of these patients have family history as well. And I recommend that you use this in your clinics. It's very simple. Trigeminal autonomic cephalalgias, a bit of a mouthful, are much less common, as I mentioned, but they're more male predominant in presentation, unlike any other chronic pain condition. The onset tends to be around 20 to 40 years. It's a really interesting condition because it's a bit like migraine. You can diagnose migraine with migraine signs, which I'll talk about in history. Trigeminal autonomic cephalalgias there's a very explicit difference between migraine and TACs, in that they're male predominant, younger, spontaneous onset, and they have these autonomic signs. So they have the ptosis, the meiosis, the flushing of the cheek, the unilateral tearing, unilateral blocked nose. And that is the nasal congestion, which you also get in migraine, can actually confuse you or push you towards the possibility of diagnosing painful rhinosinusitis. These patients have intense pain. It's called suicide headache, and there's two conditions that affect the face. There's SUNA and SUNCT, so sudden onset unilateral conjunctival irritation with tearing, which is SUNCT, and SUNA, which is sudden onset unilateral neuralgical headache in the V2, V3 region. And these conditions are very intense. They tend to be seasonal. They tend to occur at spring and autumn. Men mainly, as I mentioned, it may be onset with alcohol and exercise. It's a rare condition, but many patients we see have had inappropriate ENT surgery and dental surgery for their conditions. This pain, unlike migraine, where migraines have the photophobia and the phonophobia, they curl up and lie down in a dark room for hours or days, but the episodes can last for. These guys basically present with hypothalamic behavior. They're basically bashing their head against the wall. If they get an attack when you're near them, they might hit you. They're very aggravated. And it's basically very sharp shooting neuralgia form type pain attacks, usually centered behind the eye, as you can see in this diagram, that can spread to V2. So these are the different types of the TACs. You need to know this off by heart, but essentially the key features are the male presentation, 20 to 40 years old, spontaneous onset, attacks during the same time. The attacks happen at the same time during the day. Often they wake them up at night. Often the attacks will start very early in the morning, 2 or 3 in the morning. So they're very sleep deprived. They have hypothalamic behavior, which is opposite to migraine, where you lie down in a quiet room. They have the autonomic signs, and the cluster is because they cluster in seasons in spring and autumn. So these are really, there is some evidence around these patients having prior abuse and neglect. Sexual abuse, many of these male patients report in a significant proportion. And that's something we assess on our chronic pain patients. It's really relevant. So there's a few papers. We published one recently around whether this is attack, or is it toothache, or is it rhinosinusitis. And you can see here that there's facial symptoms quite commonly lower in these patients. And this is a sad picture of a lovely 36-year-old gentleman with 15 years of intense episodic V2 pain on the left-hand side. And he's actually documented all his treatment. He didn't have any sinus surgery, which is unusual in these patients, but he had lots of dental procedures. He's obviously not dentally trained. He's put the procedures on the wrong side. You can see he's gone from dentate to completely edentulous here, and he's still got the pain. He had 141 courses of antibiotics. I mean, this is absolutely makes you want to weep, but we see these patients all the time. So this has significantly changed our approach. And you can see here, this is an recent audit of the percentages of patients we see on our clinic. And 30% of our patients presenting with chronic orofacial pain are migraine. We're not actually diagnosing idiopathic pain at all, really, very rarely. So persistent idiopathic facial pain or intraoral pain, we do not diagnose. Most of the misdiagnosed or idiopathic facial pains we've talked about before are either attacks or migraine. So we're really getting to the bottom of this, which is fantastic. And this is thanks to Peter Goadsby's team, who works with me at King's, and Jan Hoffman, who's head neurologist. So this is actually showing you the proportion of patients that we see with headaches in our clinic. And this is working with a headache neurologist. It's fundamentally changed our practice and fundamentally changed my education, which I'm trying to impart to you here. You can see that a huge numbers of attacks and migraine patients coming through our clinics, which Peter couldn't believe when we first started off working together. Claire, as you know, I work with, very fortunate. She's written a fantastic article and update, and I can supply you with some of these key documents if you want. She did a really good summary actually for Dental Update. I'm on the editorial board, and she really highlights here how it's so easy to misdiagnose these patients presenting with chronic rhinosinusitis, 50% reporting pain, because they basically, and I'll show you some evidence in a minute, most of these patients have migraine. And you can see here that most of these patients talk about sinus pressure, pain of sinus area, nasal congestion, and rhino with migraine. So they're basically giving you the history. So they're just going to flick through these. These are key review papers showing that 90% of sinus headaches are actually migraine. And you can see here there's another one that's around 87% review. This is 88% patients with either physician or self-reported rhinosinusitis have migraine, and another one with sinus allergy and actually had migraine. So this migraine is something you need to be really familiar with. And this is another paper really accentuating the fact that you need to, a bit like I work with clinical psychologies, and Prof was talking about working with clinical psychology on the aesthetics, I work with the pain. You need to think about maybe just making sure that you've got a friendly neurologist that you can pick the brains of and refer your patients with you think might have migraine or primary headache. So there's a lot of evidence out there that actually the painful chronic rhinosinusitis is in fact primary headaches, most likely migraine. So this is probably the most important message you need to take away today. Briefly on toothache, and as I say, I never ever exclude toothache. It's very common, particularly unfortunately with COVID. Access to routine dental care has really plummeted. Waitlists have massively increased. Antibiotic consumption and A&E presentations have massively increased. And sadly, patients, this is a dental abscess up here of the tooth, patients are ending up having to have teeth extracted. Toothache is quite complex. There's healthy teeth, and actually teeth, the only organs of the body that feel allodynia, mechanical or cold allodynia in health. So dentists are very easily swayed to persuade, they get confused with trigeminal neuralgia, neuralgic type, because we see it in health all the time with cold sensitivity and dentine or a cracked tooth. Essentially, once the pulp starts to become hyperemic, you get actually hypersensitivity to A delta fibers, you get cold sensitivity and sweet sensitivity, which is short lasting and elicited. Then once the pulp is self-strangulated and you've got a necrotic pulp, you have no elicited pain, but you get spontaneous throbbing pain, which can emulate the migraine or sinogenic type throbbing pain. And then once the abscess is developed, then you get mechanical allodynia on biting on the tooth as well as spontaneous pain. So it's a great mimicker of lots of different conditions. And I spend a lot of my time lecturing neurologists and dentists about never ever excluding toothache. And this is just a couple of 3 cases here. This is a 27-year-old New Zealand guy who's actually referred to me in New Zealand. I don't do private practice, but I consulted him with a couple of colleagues who are in private practice. He'd been offered microvascular decompression for trigeminal neuralgia, and he had actually basically a dental abscess on upper left 6. This patient here was a 56-year-old lady. You can see there's a wisdom tooth buried there. It's actually got caries, it's tooth rot in it. Her dentist was basically taking local x-rays, saying the teeth are fine, didn't realize she had a buried 8, which was carious and causing infection. And she had pain on and off, idiopathic facial pain label for 5 years before we picked her up in the clinic. And then this gentleman here is the bread and butter of my patients I see. I did a PhD in trigeminal neuropathy and neuropathic pain. This patient here had an implant, and on the adjacent to the tooth of the implant, there's an abscess. So never, ever, ever discount toothache, because toothache can mimic all sorts of other conditions. Claire did a lovely section in her paper, which I can share with you around is it rhinosinusitis toothache, and it's really interesting that 10% of all sinusitis cases probably have an odontogenic cause, and that may be increasing with obviously with COVID, with the dental abscesses becoming more prominent. But also actually with implant surgery as well, there's now a two-way, unfortunately, a two-way feed with implants either being lost or displaced in the maxillary sinus and not being reported, or the patient not being told, being involved in a few medical legal issues there. But also dentists are keen to refer the patients to the ENT to make sure the sinus is clear before they do the implants to maximise success for implants. How can jaw joint pain or temporomandibular disorders mimic facial pain? As I mentioned, it's the most common chronic pain that we see in our dental clinics. usually stress related. The peaks, the epidemiological peaks are O levels, A levels, then an exit of university exams, and then divorce, sort of 40s, 50s. So it's very much stress related. There used to be this belief it was dental related and bruxism related. It's not at all. Nocturnal bruxism is basically a sleep disorder. It doesn't cause muscle pain. So that's completely irrelevant. What it does do is destroy your teeth. So you need a soft splints to protect your teeth. But actually the joint disorders are divided into degenerative joint disease, arthritis, which is incredibly rare, muscle or joint pain, which is what we see frequently, but that's mainly related to migraine, and then internal derangements where the patients might open lock, or open close, where the disc is actually not functioning with the condylar head. And this is all on this wonderful website, how to diagnose it if you're interested, and diagnostic loops and assessments. There's a standardized assessments, both axis 1 and axis 2. The key thing you need to know about jaw joint pain is, you literally just examine the patient, press over their jaw joints, and they'll back off and just, that's very tender, either right or left or bilateral. You can palpate the masseter and temporalis, and if they've got sensitivity there, they've got myalgia and or arthralgia. Now, a temporomandibular arthralgia, myalgia can refer pain to upper molars and lower molars, but also, as I mean, upper molars to B2 region. So it can present as bilateral, episodic, or chronic midfacial pain, which is why you need to be aware of that. Both migraine and TMD patients have high comorbid pain rates, so they have high levels of neck pain, back pain, and other reported pain. So they're probably in that group of those phenotypic, genotypic patients who are going to be ending up with fibromyalgia and chronic widespread pain. You don't know if you can hear this. This is a patient, many patients we see who basically has got post-traumatic neuropathic pain after routine dental treatment. We see a lot of them. And that's another condition that can present with either episodic, elicited, or chronic neuropathic pain in the B2 region. So by definition, neuropathic pain is a lesion or disease of the peripheral sensory nerve system. Most common neuropathic pain is diabetic neuropathic pain, rarely see that in the face. MS will cause it, and the traumatic is the most common by far, post-surgical, probably consists of around 80% of patients seeking pain in chronic pain clinics now are post-surgical pain. Trauma from surgery is most common, but obviously other trauma, motorbike accidents, phantom limb pain is an example, chronic post-surgery pain, chronic herniorrhaphy pain, chronic post-thoracostomy pain are the biggies. Chemotherapy can cause persistent neuropathic pain through different toes, radiation is thermal as well. And then we've got our other neuralgias, our trigeminal neuralgia. So we see loads and loads of patients in our clinics which have had previous dental surgery, implants, local anesthetic injections, block injections, thermal surgery, and non-thermal extractions, and endodontics, root canal. And if their pain coincides in the midfacial region with an onset with dental treatment or surgery, you have to think about neuropathic. The features are either a spontaneous neuralgia or elicited neuralgia, a bit like trigeminal neuralgia. This is actually a 1,331 series of patients I published for my PhD students last year. And you can see here that most of the areas affected are in the mandible because it implants the molar and local anesthetic injection nerve injuries. But you can see some patients have increasing implants and bone augmentation. We see quite a few patients with midfacial and neuropathic pain, usually unilateral, absolutely onset at the time of surgery. They may have had pre-existing infection pain, and you can just ask them, did the pain before the surgery respond to non-steroidals, antibiotics, paracetamol? Yes. Inflammatory pain. If it didn't, it's very likely, and then it changed after surgery, where it doesn't respond to those, and you've got your neuropathic pain. There's a few reports, explicit reports around post-functional endoscopy and sinus surgery for neuropathic pain. I think there's probably an awful lot of cases out there. We see quite a few. But of course, the elephant in the room, again, going back, is the cancer diagnosis. And increasingly pick up quite a few fungal infections in patients with foreign bodies left in the antrum, and that might be, the maxillary antrum might be root canal bits and pieces, bits of teeth, and implants. So just be aware that's a possibility. One of my team published this a few years ago around non-traumatic peripheral neuropathy seen around the head and face. And you can see here quite a few of these are dental tumours, central tumours, but don't forget sickle cell anemia can cause vasculitis, intense vasculitis, neuropathic pain, past fractures, multiple sclerosis, and periapical infections. So dental infections are the most common adjacent to the inferior alveolar canal. Talk briefly about trigeminal neuralgia. There's an updated classification in the ICOT and the ICHD3. There's 3 groups of trigeminal neuralgia. One group is classic with a neurovascular conflict with either basilar or cerebral artery or veins pressing against the trigeminal stem, right coming out of the midbrain pons region. And it may be classically elicited, onsets around 50 to 60 years. Females, male, sort of equal predominance, completely spontaneous onset. Often the main complaint is they can't wash or touch their face, can't shave, can't put makeup on, can't brush their teeth. Classically, they've seen the dentist because it's a very allodynic type elicited pain, so pain to touch. And obviously, it's in the dental region. They immediately think that it might be dental pain. And unfortunately, a lot of dentists think it might be dental pain. And these poor patients have lots of treatment done. But generally, it's perinasal. So it's often unilateral, usually V2, V3, very rarely V1. And these patients, it's really life-stopping, sudden shock pain. It's life-stopping. They're very fearful of the pain coming back, and they won't touch their face when they're telling you about the possibility of it starting, and they won't let you touch their face either. It's very difficult to examine them. So this is a very rare condition. Unfortunately, it gets loads of press because everyone knows about it. GPs know about it, medics know about it, dentists sort of know about it, but it's very rare, but you need to be aware of it. There's a big, interesting new research now that maybe NAV 1.6 channel related, and about 18% of these patients have familial TM, which is very interesting. When we see these patients, we exclude central causes like multiple sclerosis, so gadolinium enhanced scan, neurovascular conflict, and obviously we're looking for space occupying lesions. Postherpetic neuralgia, I'm not going to spend too much time on. We very rarely see that in it's another neuropathic condition in the face now. Very well managed by GPs with aggressive treatments with tricyclic antidepressants, antivirals, and steroids. It seems to have nipped the buds, as we very rarely see these patients in our secondary tertiary care units. And then I mustn't forget the last pain, which is the nociplastic pain or the centralized pain. If you have a patient with chronic or intermittent midfacial pain, they have headaches, they have neck pain, they have back pain, they have vulvodynia, they have IBS, they have multiple joint pains. There's a very simple survey which we use on all our patients, which scores the patients out of 35, and if they have 19, then they basically a fibromyalgia patient, and it's a very simple questionnaire about pain sites and whether they have fatigue or tiredness or wake up tired or feel fatigued during the day. So again, if you've got multiple pain patients, just be very, very aware, because they probably it's probably part and parcel of their generalized nociplastic pain. And then last but not least is the heterotopic pain, very rare, but I've seen 3 patients in the last 18 months with cardiovascular angina-related left facial pain, usually around the V3 region, but can go to the V2 region. So basically exercise-induced pain. Psychogenic pain, we're picking up an awful lot of patients. That's very easily examined. So if you get the patient to flex their neck up and down or reach over, if you get familiar pain, radiate upwards, cycle 2-3 nerves supply the skin over this region here, not the trigeminal nerve, then you can actually refer the patient on with an MRI neck scan to a rheumatologist. So just briefly running through sort of the key points, that the sort of pavement cracks that not to fall in. The site, don't fall into the site trick, but this is rhinosinusitis pain. This is more likely to be migraine, and I've shown you quite a bit of evidence about that. Think about onset. If there is previous surgery or trauma, and even if there's a significant life event like a dog dying, husband dying, probably shouldn't put it in that order, a significant illness in a child, that emotional component can onset a pain in a vulnerable person. So ask about significant events, but also prior surgical events around the onset of the pain. Neuropathic pain, by definition, can onset up to 6 months after the event, but that's usually for radiation chemotherapy. Most of the surgical induced neuropathic pain is immediate, related to the surgical event. And then you can ask about radiation. We don't tend to talk about that too much in our patients, but in obviously psychogenic pain and jaw joint pain, it may be important. The character of the pain is really important as well. So usually neuropathic will be a sort of sharp shooting electric, pins and needles, episodic type pain, although some patients can have a background burning pain. And then the neurovascular headaches and toothaches tend to be a throbbing, dull ache type pain, very much like rhinosinusitis. Biggest differentiators, and there's one slide you had to take a picture of and put it up in your clinic, are these questions you need to ask your patients. So the migraine signs, photophobia, phonophobia, so light sensitivity, noise sensitivity. These patients actually are sensitive individuals, are hypersensitized between the episodes, not just during the episodes. Aura is really quite rare in migraine. Migraine without aura is much more common. Unable to move their head or neck during the pain episodes, they just need to lie down in a dark room, nausea, vomiting, dizziness. And the patients will often tell you they can't wash their face and can't brush their hair because of that sensitivity. They'll have probably a past history of migraines or a current history of ongoing migraines and a family history of migraines. And then on the right-hand side, you've got the autonomic signs, which I mentioned. These are the parasympathetic signs that will sway you towards a trigeminal autonomic epiphyseal diagnosis. And I've been through this already. Exacerbating factors, basically, if the pain doesn't respond to anti-inflammatories or antibiotics, if there's no effective cause, then it's unlikely to be inflammatory pain. Very simple. Life isn't always that simple, but they may have several pain conditions, but it's a very simple question to ask. And then if the pain is absent or less in the morning and builds up during the day and is absolutely noticeably worse in stress or tiredness or illness, then it's probably neuropathic pain. So I think Prof. Hesham was talking about say assessment. I say history, listen. So the patient will tell you the diagnosis of William Osler. So listen to the patient, they will tell you the diagnosis. Pain is all about history, the diagnosis. It's not about examining the patient, it's all in the history. We on our clinic do a stratified approach to our patients. So we do a huge amount of phenotyping of the different pains that we see. And this is based obviously on Socrates, which I've been through briefly with you. As Prof. Hesham also mentioned, it's really important to identify the type of patient you have. And I very politically and correctly divide my patients into soccer type patients or Eeyore type patients or rugby type patients or Tigger type patients. So one patient will be absolutely massively compromised by what we think is maybe just a simple small toothache. Whereas another patient who's got massive trauma to their face, huge chronic post-surgical pain, is just getting on with their lives and bouncing along like Tigger does and just moving on. So that's a really important part. We do a very, very detailed access to assessment in our patients because of the pain is basically predominantly access to. It's biopsychosocial, but predominantly access to. And we pick up a lot of mood disorders, personality disorders, delusional, all sorts of things in these patients, and obviously prior abuse and neglect. So that's a really important part of endotyping the patient. This is a summary slide as well. It just runs through how we might manage these patients, very brief synopsis for nociceptive pain, for inflammatory pain, for neuropathic pain, for the neurovascular type pains, and the centralized dysfunctional pain or nociplastic pain. So this summarized sheet is really quite basic. I don't think I need to mention too much. You know about neuropathic pain, responds basically to tricyclic antidepressants and the gabapentinoids, and maybe the SNRIs as well. Duloxetine is very effective. And then specifically for trigeminal neuralgia, I'm talking about Tegretol is specific for that, and possibly the Lamotrigine if Tegretol can't be used. 8% of patients get a Stevens-Johnson syndrome type reaction, which they have to be warned about. Neuropathic neurovascular pain, essentially medication overuse headache, that's cold turkey for 12 weeks. The patients comply with that, often the pain goes away, they don't need any painkillers. So I'm quite rude to my patients, they've got a rattling handbag. You need to divide your migraine into episodic and chronic. That's basically less than 15 days a week, 15 days a month is episodic, more than 50 days a month is chronic. And then essentially you can use triptans as treatment along with paracetamol and vitamins, so vitamin B complex, coenzyme Q10, magnesium, and zinc are all actually prophylactic for preventing migraines. So that's a very useful thing to give the patients. Chronic migraine need preventatives, so you're thinking about more about hypertensive, if they're hypertensive, GON blocks, beta-occipital nerve blocks, and possibly botulinum toxin, which is now NICE recommended. And TAX, the go-to drug, is lamotrigine. So there's so specific mechanisms. Talked about how the importance of endotyping the patient. So we look at all aspects of our patients, the demographics, the cultural ethnicity, psychological factors I mentioned, lifestyle. Comorbid pain conditions is a really important question. Sleep is really important question that drives pain. We're beginning to look at autonomic tone and microbiome and these other aspects that might be driving chronic pain. We know that pain is complex and it's biopsychosocial. So this is just a synopsis of how we might think about endotyping our patient on the left-hand side, looking at the phenotype pain that we decided on, and then hopefully actually tailoring the treatment specifically for those patients. As I've mentioned, this is one of Bill Maxner's who passed away. He was a giant in pain research in the US, passed away last year, sadly. Just emphasizes the sort of genetic and the endotype of the patient, the social circumstances, and the psychological access to and the environment, how important it is to think globally when you're assessing any patient, but particularly a pain patient. So that's really just summarizing. The most important thing of managing these patients is getting the right diagnosis. So listen to the patient, empathy, education, explanation, expeditious, efficacious treatment, lots of ease, and making the patients understand what you're talking about, which Prof mentioned. So managing the patient's expectations. These patients have been, and multidisciplinary care, these patients have been messed around previously so commonly. They have lost all faith and trust in the clinician. So it's really important to say, look, I'm really not quite clear about this diagnosis, but let's do this, let's try this, and see where we go from there. So hopefully I haven't run over my time. I suspect I might have done, but I have finished. Thank you very much.
That was superb. So what you've managed to do is to elaborate on what is a very, very sort of challenging area. These are complicated patients who, as you've alluded to a few times there, who've been messed around, who have been passed from pillar to post, often with poor diagnoses or a lack of diagnosis, and they're frustrated and feel helpless by the time they arrive at your door. So it's really sort of enlightening to hear that they're getting this sort of quality or level of service across centres in the UK. I like treating these patients. I think they're a diagnostic challenge. They're akin to the dizzy patient for the otologists. I don't mind spending the time with them and sort of teasing out what their different causes for pain are. And I suspect that gives you a bit of a thrill as well, having just listened to you.
A thrill and still a dread and sinking feeling. I think the chronic pain patients that come into your clinic, if you're not used to dealing with them and you don't have that team support, they do suck you dry. At the end of my clinic on a Monday, I'm not fit for anything. Mentally and physically, I'm completely, exhausted. But it is an important area. And as I say, I'm very lucky that I work with such a great team who voluntarily work with me. I don't run the team. But that's made a huge difference. And it's very encouraging that I think we are making a big difference to our patients. We still have those heart sink patients who will never, ever get better. But fundamentally, now we know what's driving that. And a lot of it is prior abuse and neglect in childhood, significant life events which are not physically traumatic. And we're really beginning to understand these patients a bit better.
One thing that I find really reinforces patients' perception that it's a sinus problem is they will show you pictures of facial puffiness and maybe even nasal congestion, and they might have a husband or someone that reiterates, I can physically see when the sinus problem is there.
Yep.
Can you just sort of unpick why that happens? Or
well, they're classic signs, they're classic symptoms in migraine and TAC. So the parasympathetic signs where you have the redness, puffiness, and the unilateral nasal congestion is, well, in migraine, if it's bilateral, but in TACs, it's usually unilateral, very rarely bilateral. They're classic symptoms of the increased parasympathetic tone. So yes, they do have it. They're not making it up. But it's not rhinosinusitis. It's migraine or a TAC.